Alright, want me to record it. Yo, Jax, how do I make this bigger?
Mine can't go bigger either.
You go up here.
Oh.
Yeah.
Ah,
You should
okay.
link them.
Thank you so much. Yeah. Fit. Oh, it doesn't fit. It doesn't fit. No. Kevin has nice hair. I like it. Right on the top. Gabby, you're too happy today. I'm just kidding. Just be happy. Be happy, girl.
We'll do the eye, ear, and respiratory. So, and what we try to accomplish is to look at the differences in the anatomical differences in both the eyes, ears, and the airway of children versus adults. We also like to look at those factors that are associated with those disorders or that can put those kids at risk or that can cause a problem in infants and children. You will notice that some of those are different between adults and children. We discuss the signs and symptoms of respiratory problems or eye problems, and then we'll be able to, the information that you can be able to plan a care for a child and or teach the child and the family how to take care of that problem. So, starting with the eyes and ears, you will notice that in newborn, infants, newborns, their eye ball is very large. And that can put them at risk for injury. In terms of visual acuity, their visual acuity will develop progressively as they grow. In the newborns, they are able to see approximately 8 to 10 inches distance. As the child grows, the vision will improve and the child will be able to see 2200 initially and then 2020. Okay? So with age and with development, as we said, or maturity, there is increase in functionality of the structure. Again, with the by the time the child is approximately 4 months, they should be able to focus on an object with their 2 eyes, and that is called that binocularity. Should be able to, form around 4 months. Prior to that, they can only focus with 1. Okay. In the ears, you look at the ears. The eustachian tube here, you look at the ear canal, it's like horizontal. And this puts the child, the kid, at very high risk of infection, transferring from their mouth to their ears and to the respiratory system. But as the child grows or get older and in adulthood, you see that the eustachian tube is slanted, so that there is no more direct connection between the fluid and then the ear and the respiratory and the mouth system. So those are the things in terms of the ear and the eyes that you need to know. There are other variations here that you may find, but these are the classic ones that you must know. Now, taking care of a child, or for you to, the child presents to you, be it in the emergency room or admitted in the unit and you're going to do the admission. First thing we do as we care for that child is we must get the history. So you get the information from the caregiver. That will include the chief medical reason for coming, the content of why they are there. And all the other information that you get from the caregiver. If there was a respiratory problem, there is an injury, you would like to find out what type of injury, what the child was doing, and how, and when, and all that. And then you will progress with your physical assessment that you will do. And then you will have to do your lab. If there is any eye discharges, you would like to culture that to see if we'll be able to isolate the perspective organism. Same thing goes with the discharges from the ear. Make be able to culture it and see if there is anything that grows in it. Other things that you would like to do in terms of your exam and history will also be, what the child, kind of child behavior, what the child was doing. And that we will get into more when we look at something like otitis media. And then based on all the information you gather from the parent and or the child, you'll be able to kind of come up with your nursing diagnosis of the problem, to identify the problem, and then you'll be able to put interventions in place that will help you resolve those issues that the patient has. One thing that we do so often is that we will take any intervention that we find in the book, whether it's applicable to the patient or not, and we'll put it in place. And you can do that all you want if the patient has, if there is no problem that the patient has that intervention can address, the patient is still there. You're not doing anything to help the patient. So that's one thing you have to focus on when you kind of try to develop your care plan and or put some intervention for your patient. Make sure that whatever you are trying, whatever you are offering, it's something that can address the problem that the patient has. So, having said that, the first problem that I will look at, we will look at will be the conjunctivitis, which is that inflammation of the conjunctiva of the eyes. It can be a viral infection, it could be a bacterial infection. Okay. What you notice, or it could be a chemical, from allergic reaction. Okay. But you will notice that the conjunctiva is so red, it's very red, and you have the discharges. There is one other condition in Peds that the conjunctiva will be very red, but there is no discharges. And that will be in the case of Kawasaki. So when we do cardiac, we will address that problem. So you see that the eye is just as red as this, swollen red, but there is no discharge. That will be Kawasaki. However, for our own conjunctivitis, which we all recognize, it will be that swelling, that redness, plus all these purulent discharges from the eyes. So, how do we care for it? Well, there is a discharge you can take culture, isolate the bacteria, and with that we'll be able to put appropriate eye ointment and or drugs to take care of it. Note that the viral conjunctivitis, you cannot use antibiotics to treat. Why? So the viral one will be self-limiting. So in other words, it will over time resolve itself. And what you just need to do is to treat the symptoms that present. Child may present with fever, you treat the fever. If there is those discharges or redness or tearing of the eye, all you need is just use soft face cloth and just wipe the eye and just do not rub it. Okay? If it is from allergic reaction, they can put antihistamine drops to take care of that. So in other words, for that, what you are trying to do is to relieve the symptom, and also in the case of bacterial infection to prevent spread of that infection. So this chart here is in your book, and it's just a summary of what you can see in bacterial, viral, or allergic conjunctivitis, and how you take care of it. So we said that for bacterial one, you use the eye drop, antibiotic eye drop, and or ointment. For the viral one, we just treat the symptoms and just make sure that the child's face looks clean. For the allergic one, we put the antihistamine. Another problem of the eye will be what we refer to as the refractive errors. And this is when there is a failure of light to enter the lens. So the light is entering the lens, but it does not fall directly on the retina. So there is a divergence of that light. You can have hyperopia, which means that the depth of the eye globe is not fully developed by approximately 5 years. And with that, you see that the child has a blurred vision. Or when in myopia, when the light falls way behind the retina. So the child will see at close range, but not very far. And that's a problem that, I have that problem. I can see close up, but when I take my glasses off and you are over there and you saying hello to me, if I don't recognize your voice, I don't know who you are. I can see somebody doing this. I will, just to be politically correct, I will wave back because I see a hand moving. But don't ask me who that person is. I have no clue. So, but if you come closer, yes, I will recognize you. But if I know your voice, yes, I know that's you, then I can respond up. And then people will say, oh yeah, she saw me, and then she totally ignored me. I did not see you. I don't have my glasses on. So. Again, therapeutic management here will be correcting prescription lenses. Okay. Sometimes they'll do laser surgery, but not until the person is older, 18 years of age. Again, education, you educate the person on what you are giving them. Wearing of their corrective lenses, you have to educate them. Kids, they don't like to put it on. I remember my son, I spent my money buying, in fact, I even bought a backup pair. Both the primary and the backup, we never used it until one day I found that one leg of the primary one was missing. On the backup one, the lens was missing. I'm like, why did I spend my money? But you have to kind of encourage them to do that and just get with it one. And what is the thing that the teacher, classroom teacher will, complain initially is that the child is not paying attention in class. That will be the number one complaint. And you get this report of, or the child is kind of always bending their head so much to the point that they may start having complaint of neck pain. That's the two major things that you will notice initially. And then when you do an eye exam, it comes out that the child cannot really see, cannot really focus. Okay. Another problem would be the what we refer to as astigmatism, which is uneven refraction of light rays to the cornea. So it falls on the retina, but it's not reflecting evenly. So the person will complain of blurry vision, or sometimes they see a partial letter, or they tell them to, what is that letter? When you're doing your visual acuity on them and ask them to read that spelling chart, they'll say to you they see a C or E, they may read it as a B, or like a C. They see an E, but they cannot see the whole formed letter. Again, it's due to that refractive error, and it needs to be corrected with glasses, and then they'll be able to see. This is the strabismus. Again, it's misalignment of the eyes. Treatment for this, because the eye muscles are not aligned well, so one is stronger than the other, is pulling the other one, the weaker one away, so the child is not seeing well. So what the ophthalmologist will do will be to patch the stronger eye. That way, focusing on the muscle of this one should be the one that will be working hard for the child to see. So over time, once the patch is removed, this one will train this eye successfully, and the both of them will be in equilibrium. Without doing that, so this one is weak, the stronger one will pull it. So this is not functioning. So the patch cover the strong one, okay, so now you go on vacation, and then when you come back from vacation, this one will start, will pick up. So that's what she's seeing in this particular one. And then again, they can augment it with corrective lenses. Another thing would be infantile glaucoma, which is an autosomal recessive disorder. It is congenital because it is autosomal recessive. Meaning that for the child to inherit that, for a recessive gene, both parents have to be carriers. But if the disorder is dominant, all you need is one defective gene from the parent, and that problem can be expressed in the child. So what will result here is that there is a blockage in that aqueous humorous flow, which is that liquid that moistures the the eye socket for the eyeball to kind of get moistened and nice. So with that blockage of that fluid, you have increase in intraocular pressure. Once you have a blockage in any area of the body, it's like you have a clogged drain. Your drain is not functioning well, that is backlog. Okay? So there is backlog in that flow of the aquatic fluid, so there is increase in intraocular pressure. So with that increase in intraocular pressure, it will affect the vision of the child. Okay. Child will constantly be rubbing their eyes, trying to take that thing, remove the discomfort. The eye will turn red, and then appear so enlarged, and this is what you will see. Okay. So with that constant tearing and constant rubbing of the eye, you see the redness in that eye. Okay. Again, that needs to be corrected. they do a surgical procedure or patch the eye as well to retrain the eyes, and then our role again is to educate the patient. Again, poor vision in a normal eye would be this amblyopia, which is poor coordination of the eye with the brain. So the brain and the eye is not coordinating well. That's the problem. So what the eye is seeing is not reflecting on what the way the brain is interpreting it. There is a disconnect between the two. Okay. Again, to strengthen that, also you have to kind of start patching the eye and or use the atropine drops to then go, to do a visual therapy for those kids. So all these things, I'm just highlighting them so that you know that these are, possibilities of things that can happen in a child. Nobody is going to ask you to name all of them, one at a time. But what will be your role when a child presents with a visual problem? What will you do? Educate the parents and handle them on what is going on and refer to ophthalmologist.
Oh.
This is the cataract, congenital cataract. Same type of cataract you have in adults, you have in children, so that is that the lenses is covered like something like a scale, so it's kind of not even seen, and that can lead to blindness. For the eyelids, you can see bacterial infection of the salivary gland here. Usually bacteria for this one. Or you can see like a painful, a painless cyst on the eyelid. Or you can see like a discharges on that eye. So either way, you can just see all these combination of things that can present in children. For us, the bacterial ones we must treat and we must prevent the spread of infection. Okay. That will be your primary strategy. Eyeballs can be injured because it's large and it's protruding. And kids, they squint and they're very inquisitive. They cannot discriminate what goes where. They can take something and just put in their eyes, put in their nose, put it anywhere. So, but again, or it could be accidental injury. But some of those injuries that you will see, common ones with the eyelid injury. Well, the scleral hemorrhage will be from sometimes excessive rubbing, or when we shake the child trying to quieten the child. With that, we call that eye injury, including the subdural hematoma. Okay. Corneal abrasion can also happen, or foreign body, or chemical injury. Again, when a child presents with with eye problem that warrants to be seen by an ophthalmologist. We know there is a difference between optician and ophthalmologist. Anybody know the differences? Anyone? Yes.
The ophthalmologists do more surgery. They do like the cataract surgery, glaucoma. They're the specialists.
Yeah, specialists. Yes.
Opposed to the optometrists, they're just the OD.
What is OD?
Optometrist doctor.
Overdose.
Yeah. No. Sorry.
What is OD? What do they do? Everybody know what they do? Opticians. Opticians, they can do the refractions, test your eyes for the type of glasses you can wear, and they can prescribe your eyeglasses. But they cannot do the surgery. In I need any surgery, cataract extraction, or anything whatsoever, they cannot. I better go to the ophthalmologist. Okay, so those are. So if there is any of these warrants a visit to the ophthalmologist, not the optician. When the classroom teacher complains that your child is always bending, always twisted, there is an assignment, she's always going like this, you can go to the optician. But the school nurse calls you and goes, you know what? Johnny was playing and one of the classmates hit him on the eye with his elbow. But I go to the ophthalmologist. You cannot go to the optician in this instance. So these are two different instances where that requires a medical evaluation, but you have to know who to go to in that instance. Okay? Other problems that we talked about with those disease entities can be all these visual impairment, inability to see very well, and this is what affects the visual acuity. Remember I said for the infants, it goes progressively as they grow. So again, we're putting in here by classification. Anybody that sees 20, 200 is defined as legally blind. Okay. So, if you look here, all the conditions that we talked about previously can cause legal blindness. And for the fact that the child is has one form of developmental problem, prematurity and all that, can increase their risk for visual impairment. Again, our strategy will be whatever we did in individual disease entity. That's the same thing we're doing here. We're kind of encouraging the family, referring them to where, or telling them the differences between the healthcare providers that they should be visiting for each condition. And also we have to kind of, because we are dealing with children, we need to promote growth and development, meaning that socialization within the kids and all that. So we have to do that and do the education of the child and of the parents. Okay? So whatever the problem is, that's what we're zeroing in the intervention on. So any problems with any questions with the eye? No? Okay. The absence of questions, I'm moving to here. So like we said that the ear, in children, the mutation should be still horizontal, and that increases their risk for infection. And one of those infections will be the otitis media, which is that infection of the middle ear. It can be infection, plain no infection, it can be flu when you define it in general terms. However, as we go forward, we have to note which one is the otitis media, acute, chronic, and also the otitis media with effusion. So we find that. This is very common in children because their mutation tube is short and horizontal. And again, the younger the child is, the less immunity that the child has, Because remember, we're introducing all these vaccines to introduce those antigens so that the child will form their own active immunity. But the younger the child, with the anatomic structure in place, the child has a higher risk of developing infection in the middle ear. Another thing that can increase the risk of the child developing infection in that middle ear would be once there is a stasis of fluid in that. Some bad habits, some parents and or some nurses in the nursery have is because they want to get their work quicker. They'll lay the child down, they prop the child, and the child will feed themselves. So now you're laying flat and you're feeding yourself, so the whole fluid is there. Once there is stasis of fluid anywhere, there is a stagnant fluid anywhere, that place becomes a breeding ground for bacteria. Okay? So that's something that you have to be cognizant of and to be able to teach the parents against doing that. And also prevent yourself from doing it no matter how busy the unit may seem to be. So these common organisms here could be strep, Haemophilus influenza. Those are the most common ones. There are other organisms that can find their way in there. Common symptoms that you will see is that for the child, for the very young infant, one of the first signs that you see is that the baby will be irritable. Once the child is not feeling well, you will know. First thing, they will be irritable. They will start refusing their food. You give them bottled food, they won't take it. Mommy put them on the breast, they won't stop. That will be one of your initial things that you will notice in a child, in an infant. For the older ones, 4 months and above, you see them like putting their heads back and forth. Because there is that heaviness in that ear, they can't do anything, they don't know what it is. All they're doing is just trying to, they lay on this side, they just do this way. So they're trying just to find a place that they will be comfortable. The same way you will feel if you have a discomfort somewhere, you try to change your position as many times as possible to find a place that you will be more comfortable in. Okay, so that's basically what you will see. Some of them will tug on their ears. Okay. And for the preschoolers that can talk, they'll tell you. Again, some will vocalize it if they can, but the younger ones will just be, their action will tell you that something is wrong. Now, all children, once they have otitis media, they'll present with fever. Sometimes that fever can be as high as 102, 104. They will have lots of appetite. When you look at their eardrum or their tympanic membrane, you see something like this, very bulging and red. You see something like this. So, that's the type of things you see. Treatment. Initially, what we were doing is any child that presents with a fever and tugging on their ear, we give them antibiotics. Right now, the new evidence research have supported this wait, watch and wait attitude, that the pediatricians who buy into that, in fact, the American Academy of Pediatrics recommend not to give that antibiotics initially. The child presents with a fever, and you look at the eardrum is red, they'll treat the symptoms. They'll treat the fever, they'll treat the discomfort, and they just watch and wait. However, if that child, most of the time the condition resolves itself, but if they get it and the child continues to get sicker, then they have to treat with antibiotics. But the first line treatment is watch and wait. That would be your first line. However, if the child has fluid in the ear, that's a different problem altogether. So again, we are teaching the patient and family for chronic otitis media. Sometimes they have to put the tube in to help with the drainage of that, and they'll treat with antibiotics. Because if you don't, remember, infection have no limitation to only the ear. That infection can migrate to any part of the body and can infect anywhere, including the brain. So again, this is just the definition of all the other types of otitis media. Other problems that you can see in the ear will be hearing loss. And this is one of the reasons why in the immediate newborn period, they do the hearing screening, because they would like to identify that child earlier on if there is a potential for hearing problem or hearing loss. However, these days with the use of hearing phone, what do you call it? Headphone. You young ones, if you need to buy a stock, you better buy stock where, yes, because you will make a lot of money later on. I mean,
The big ones.
what? Yeah, because
too loud.
Yes.
You could hear like 2 meters
Yes.
apart.
And then you can imagine if you are standing away from that person, you are hearing it and you are vibrating. What is going in that eardrum? So that's why I said, you better buy, better invest in a
It's not doing it. I can't believe it. Yeah, my computer just froze.
Later over time.
Okay.
But hey, that's a public health issue that we have right here. In fact, I don't even know how we will even begin to teach people about loud. Yeah. I cannot, I mean, it's like everybody, young and old. In fact, the older ones are even joining the bandwagon and even doing it. I'm like, you know better than this. Okay, well, that's our issue, that's our society. Again, our management here will be, of course, with the hearing aid so that you can hear some more. You need to promote that communication somehow. Or in fact, if you need an additional job, additional training, learn how to do sign language. You will get a lot of calls to come in and demonstrate your system. Okay. Okay, so that's the ear. Any questions on the ear before we move on? Questions? No? Okay, can we take 10 minutes break?
Yes, yes we can.
Um,
Yes we can, baby.